Bacterial meningitis. In this session, we will talk about acute bacterial meningitis. Meningitis is a life-threatening infection of the leptomeninges, that is the arachnoid matter and the pia mater surrounding the brain and spinal cord, and it also involves the subarachnoid space. Bacteria, viruses, fungi, and parasites, all of them can cause meningitis, but the most common etiology is bacterial. Bacterial meningitis can be of two types: acute bacterial meningitis and chronic bacterial meningitis. In this session, we are going to talk about acute bacterial meningitis. Acute bacterial meningitis is an acute purulent infection of the meninges characterized by elevated levels of polymorphonuclear cells in the CSF. There are several causes of acute bacterial meningitis, out of which the commonest causes include Streptococcus pneumoniae, Streptococcus agalactiae, meningococcus, Listeria monocytogenes, and Haemophilus influenza. In the neonates and in the elderly, in both of them, Streptococcus agalactiae and Listeria monocytogenes are the common causes. Besides, in the neonates, gram-negative bacilli like E. coli and Klebsiella are also common causes of meningitis. Pathogenesis, transmission, person-to-person transmission through droplets of respiratory secretions takes place through nasopharyngeal carriers or through cases, and through the nose it is entering the body, and from the respiratory tract it can travel through the blood to the CNS and cause meningitis. So the routes of spread to the CNS are hematogenous route more commonly. Besides that, from the nasopharynx they can also go to the CNS directly through the cribriform plate, and besides that, even anatomical defects in the CNS can lead to meningitis. Predisposing factors for bacterial meningitis include age. Neonates are at higher risk of meningitis. Vaccination. Haemophilus influenza vaccine has reduced the incidence of Haemophilus influenza meningitis drastically. Besides that, alcoholism, diabetes, immunosuppression, splenectomy, etc. are also other predisposing factors, and presence of CSF shunts and breach in the blood-brain barrier are also predisposing factors. Clinical manifestations of acute bacterial meningitis. Incubation period is about 2 to 10 days. Various symptoms include fever, vomiting, headache, stiff neck, decreased consciousness, occasionally photophobia, and there are several signs like signs of meningism like nuchal rigidity, Kernig sign, and Brudzinski's sign. Fever, stiff neck, headache, confusion, increased sensitivity to light, and nausea and vomiting are the common symptoms of acute bacterial meningitis. It can complicate to meningoencephalitis when it spreads to the brain parenchyma. And one organism-specific finding is purpuric rashes seen in meningococcal meningitis. Lab diagnosis of acute bacterial meningitis includes specimen collection and processing, and CSF can be used for culture. That is the ideal specimen for meningitis. Besides CSF, even blood can be taken for culture. So blood culture is also a useful investigation. For bacteriological investigations, CSF should not be refrigerated because the common pathogens of CSF, that is meningococcus, pneumococcus, and Haemophilus influenza, they are sensitive to cold and they will die on exposure to refrigeration. So for bacteriological examination, CSF should not be refrigerated, but for molecular diagnosis, CSF can be refrigerated. Cytological and biochemical analysis. CSF contains more than 1000 leukocytes per microliter and predominantly neutrophils in most of the cases of acute bacterial meningitis, while only in one case, that is in Listeria monocytogenes, there is increased lymphocyte count rather than neutrophil count. There is increased protein, decreased glucose, and increased CSF pressure. CSF microscopy, gram staining can be performed. In gram stain, if a flame-shaped gram-positive capsulated diplococci are seen, then they are suggestive of pneumococci. If capsulated gram-negative diplococci are seen, they are suggestive of meningococci. Pleomorphic gram-negative coccobacilli are suggestive of Haemophilus influenza. Heap smear and centrifugation can also be used for microscopy for gram stain. Here in this photograph you can see pneumococcus, diplococci, gram positive diplococci with capsule, and another figure you can see Haemophilus influenza, that is gram negative bacilli with pleomorphism. Direct antigen detection test can also be used for meningitis, for acute bacterial meningitis. Lattice agglutination test can be performed. Lattice agglutination test detects the capsular antigens of the common agents of meningitis such as pneumococcus, streptococcus agalactiae, Neisseria meningitidis, Haemophilus influenza or E. coli. Culture can be done. Chocolate agar, blood agar, McConkey agar can be used for culture. Besides that, blood culture can also be done. Incubation is done at 37 degrees Celsius for up to 48 hours. For identification, recent modern and automated methods like Malditov and Vitek can also be used. These are the photographs of blood agar and McConkey agar. Molecular methods can also be used for diagnosis of acute bacterial meningitis like multiplex PCR and multiplex real-time PCR and biofire film array. Now, one by one, agents of pathogenic meningitis. Pneumococcus is the leading cause of meningitis, with about 50% of cases being of pneumococcus in origin. Pneumococcus lives as a commensal in the human nasopharynx. From the nasopharynx, it can go to the brain through the cribriform plate, or it can grow through the bloodstream, that is hematogenous route. The major virulence factor of the pneumococcus is capsular polysaccharide, the C carbohydrate antigen, the pneumolysine and autolysine. Risk factors for pneumococcal meningitis include otitis media, alcoholism, splenectomy, diabetes, and complement deficiency. Mortality remains high despite of antibiotic therapy in case of pneumococcal meningitis. Meningococcal meningitis. Meningococci can cause outbreaks and epidemics of meningitis. The capsular polysaccharide is a major virulence factor of meningococcus. There are 13 serogroups, out of which 6 serogroups are more common, that is A, B, C, X, Y, and W. They account for majority of the cases. Epidemiology. Meningococcus can lead to sporadic infection, to endemic, hyperendemic, and explosive epidemics. Out of the 6 groups A, B, C, X, Y, and W, group B and C are more common now. In India, it is more common in North India, in the winter and spring seasons, and in early childhood. Pathogenesis. Humans are the only natural host of meningococci. They live as commensals in the nasopharynx, and nasopharyngeal carriers can transmit meningococci to other people. Droplet inhalation is the major route of transmission, and spread of infection from the nasopharynx to the meninges can take place through hematogenous route or through direct spread. Clinical manifestations. Rashes can be seen. A non-blanching rash is more than 80% of cases can be seen in meningococcal meningitis. Septicemia can occur. Waterhouse-Friderichsen syndrome can occur. In Waterhouse-Friderichsen syndrome, there is shock, DIC, and multi-organ failure. Chronic meningococcemia can occur, and post-meningococcal reactive disease can occur in which there is arthritis, rash, iritis, pericarditis, polyserositis, and fever. Prevention of meningococcal meningitis can be done by chemoprophylaxis as well as by vaccines. In vaccines, bivalent vaccines having A and C serogroups and quadrivalent vaccines having A, C, Y, and W serogroups are available. Indications for meningococcal vaccine for high-risk people include contacts of patients during outbreaks, splenic dysfunction, terminal complement component deficiency, and laboratory staff at risk. Serogroup B is not immunogenic. The capsule is not immunogenic, so serogroup B vaccine is not prepared. And the meningococcal vaccine is not effective in children less than 3 years of age, and so it is given in above 3 years of age. Conjugate vaccines are available which are more effective than the polysaccharide vaccine. Haemophilus influenza meningitis. Haemophilus influenza meningitis has reduced drastically because of vaccine of Haemophilus influenza. Capsular polysaccharide is the major antigen of or virulence factor of Haemophilus influenza, and Haemophilus influenza serogroup B. Out of 6 capsular serotypes, serotype B is the most virulent type, and it is responsible for majority of infections of Haemophilus influenza. Pyogenic meningitis and subdural effusions can be caused by Haemophilus influenza type B. Group B streptococcus can also cause meningitis. Group B streptococcus is also known as Streptococcus agalactiae. It is a major cause of neonatal sepsis and meningitis. Neonatal sepsis can be of two types: early onset type, which occurs during the first week after birth, and late onset type, which occurs from 7 to 90 days after birth. Gram-negative bacilli meningitis. Gram-negative bacilli cause meningitis in individuals with chronic and debilitating diseases such as diabetes, cirrhosis, or alcoholism, and those with chronic UTI. Gram-negative meningitis is secondary to various procedures like neurosurgical procedures, commonly craniotomy. E. coli and Klebsiella are common causes of meningitis in the neonates. Pseudomonas in post-operative or post-traumatic patients. Acinetobacter in post-neurosurgical meningitis. Listeriosis. Listeria is a foodborne pathogen. It, particularly in the neonates, pregnant women, and elderly people, it causes serious infections. It is an ubiquitous saprophyte which causes episodic disease in birds and animals. Listeria monocytogenes is a gram-positive coccobacillus with beta-hemolytic colonies on blood agar. Human infections of Listeria monocytogenes are acquired by consumption of food, contaminated milk, soft cheese, and several types of ready-to-eat foods, including meat. Extremes of age are more at risk of acquiring infection. Proton pump inhibitors increase the risk of infection by reducing the gastric acid-mediated killing of Listeria monocytogenes. And pregnant women and immunocompromised individuals are more at risk of acquiring infection. It is found more commonly in the stored foods because it survives refrigeration. So stored foods can be an important source of Listeria monocytogenes causing food poisoning. Pathogenesis, it can survive intracellularly, and it can migrate from cells to cell through adjacent epithelial cells through cell-to-cell transfer. Clinical manifestations of Listeria monocytogenes infection. In pregnant women, it can lead to fetal complications like abortion and preterm delivery. In maternal complications, it can lead to flu-like symptoms, bacteremia, and rarely meningitis. In adults, it can lead to bacteremia and meningitis. And an important point is that in kidney transplanted patients, it can lead to meningitis. Symptoms of listeriosis include fever, chills, headache, backache, muscle ache, nausea and vomiting, and upset stomach. Staphylococcal meningitis, Staphylococcus aureus, as well as other staphylococci, that is coagulase negative staphylococci, can cause meningitis following invasive neurosurgical procedures, particularly ventricular shunting. That completes the topic. Thank you.